I found that the earth was not round in the way they write. Rather, it is in the shape of a pear, all very round, except where the nipple is, which is higher there, or like someone who has a very round ball, and in one place it was like a woman's breast placed there, and that this part of the nipple is the highest and closest to the sky, and is below the equatorial line, and in this oceanic sea at the end of the east. That was top explorer and thoroughly mediocre oncology expert, as well as mediocre cartographer Christopher Columbus on his third voyage across the Atlantic when he was going completely and utterly nuts. But much like Christopher Columbus in his assessment of the world, we, on today's episode of Oncology for the Inquisitive Mind, are going to be speaking about breast cancer. So, similar, I guess. I'm here with Josh Hurwitz, who is currently face palming at my, quite frankly, brilliant and very relevant introduction. But Josh, I guess we're going to talk about the most common type of metastatic breast cancer, and that's the hormone receptor positive breast cancer space.
We definitely are, Michael, and thank you for, as always, that brilliant introduction. I did not know Christopher Columbus kept a diary while he was going mad, but he obviously did.
Apparently he kept two. One to basically show to his crew and lie about where they were in the Atlantic when they were completely lost, and one that was the honest truth of, I have no idea where I am. The things you learn on this podcast, right?
Yes, and you can tell your patient, you can all tell your patients and your colleagues about this random fact.
Absolutely. So, Josh, I think you've got the duty of giving us a bit of background on hormone receptor positive breast cancer.
I do, Michael, and thank you for highlighting what we're talking about today. Hormone receptor positive breast cancer is, like many of the cancers that we talk about on this podcast, is rapidly developing and changing. There are a huge number of trials looking at treating hormone receptor positive breast cancer, but let's take a step back. The last few decades, since the 1980s, have seen a drastic increase in the number of treatment options in hormone receptor positive metastatic breast cancer. And Mikey, as the first question that I'm going to throw out here today, what do you define as hormone receptor positive breast cancer?
That's a very good question, because it is a spectrum, isn't it? It's expressed, or the estrogen and progesterone receptor positivity is expressed as a percentage.
Mm-hmm.
The cutoff, though, I guess, is a matter of debate. Is it basically anything that's greater than 20 or 30% positive in the estrogen or progesterone setting, or am I completely underselling it?
You would think that, but I think the ASCO guidelines state that if it's 1% or more, and that's also progesterone, if it's less than 10%, then generally it's considered a low hormone receptor positive breast cancer, but it's still positive.
And that's the entity of effectively triple negative, isn't it? Where we and ah about giving hormone receptor positive treatment, which we're going to talk about this episode, but we also sort of think that it's much less likely to work.
Exactly, Michael. And I think it's a really difficult space, because sometimes it does work, sometimes it does not. But if you think of someone that has positive receptors and, someone has 95%, likely they're going to respond better than someone that has 1%. And whilst I've spoken briefly about the development of hormone receptor positive breast cancer treatments, how it's improved, there's actually been drastic increases in treatments. If we talk about a chronological order, let's start with the SERMs, which are the selective estrogen receptor modulators. So I'm talking about, I think that's tamoxifen. You've got the aromatase inhibitors, letrozole and anastrozole. And then you've also got the SERDs, the selective estrogen receptor degraders, which is kind of, I think, the next line of therapy from an endocrine perspective. Now, if you're lost, that's okay. I think the important thing to talk about here is hormone receptor positive breast cancer overall survival. It continues to increase. I believe in the metastatic setting, it's I think it's 55 or 57 months, so it's pretty high. And there are multiple lines of therapies. And of course, when you talk about molecular targets and options, that's also changing. Today, I'm going to briefly talk to you about a combination therapy before we go into our trials, which is a combination of CDK4/6 inhibitors plus an aromatase inhibitor. Michael, do you know much about the CDK4/6 inhibitors?
Josh, you're going to have to give me the full encyclopedic summary on this one. I know that CDK is a collection of intracellular cyclins, from memory, that are involved in cell proliferation, like all of these molecular oncological targets are, that is involved in cell proliferation and avoidance of the normal apoptotic mechanisms. Is that a general enough answer for you?
That's a great answer. Here were great general answers on oncology for the inquisitive mind.
Yes, it's like if you're quizzed on a ward round, speaking to our junior listeners, and your consultant asks, what is the mechanism of this drug that I've never heard of? If you say it interferes with cellular mechanisms that stimulate cell proliferation and avoid apoptosis, you're pretty good bet for getting it right, at least partially.
That's exactly right. But you're right in saying it is inhibition of the Cyclin Dependant Kinase 4 and Cyclin Dependent Kinase 6, CD4/6 inhibitors, right? And the reason that these came about is that they realized that with the baseline endocrine resistance or endocrine therapies, there was huge resistance. So CDK4 and 6 are not only essential for G1 and S phase cell cycle transition, but also play a central role in the growth of hormone-positive breast cancers. In theory, prior to these development, if you inhibit these, you can inhibit the cancer, and thus many drugs were born. The three main ones that you might have heard of are Palbociclib, Ribociclib, and Abemaciclib. And all of these have been approved by the FDA, the TGA, the PBS for treatment of metastatic hormone receptor positive breast cancer. In preclinical models, I would say Abemaciclib as an example, it would promote sustained cell cycle arrest, leading to apoptosis or senescence with short-term inhibition of the particular cancer, and then they combine it. I think if we look at the future of hormone receptor positive breast cancers, because what do you do at some stage when people progress on these drugs, which ultimately most people, if not everyone, does? And this is when it gets a little bit more tricky. Usual second-line therapy is that of chemotherapy. Predominantly, people might use capecitabine as the first line in the advanced setting after CDK4/6. Sometimes they switch to fulvestrant rather than an aromatase inhibitor. Moving on, we've got things like genetic targets. So what I'm thinking of, ESR1, so estrogen receptor 1. So 30% of people, I think it's actually 50% now, have this mutation, which is essentially endocrine resistance. Now, SERD agents, which I mentioned previously, like fulvestrant, was the first in class to be approved, and they found that it actually works with people that have ESR1 mutations. This is a bit of a rabbit hole because there's multiple other resistant mechanisms to think about. So PIK3A mutations is another big one that people are looking into, and there's quite a few directed agents currently in trial at present.
But it's fair to say that the success of CDK4/6, as we'll sort of talk about in a second, hasn't really been replicated by any of those more novel agents, particularly PIK3 kinase, which was touted as the next big thing and hasn't really lived up to its potential. But as you say, very much a rabbit hole and probably not something we should get into in any great depth on this episode.
No. So I think the summary of when we talk about hormone receptor positive breast cancer in a metastatic setting is most patients should be able to tolerate at least one of these drugs. And while they all have their benefits and limitations, which is what this episode is about, they are the gold standard across the globe.
That's a very good primer for the three studies that we're going to talk about, and I guess we'll be able to get through these fairly quickly because they share a lot in common.
Yes, can you paint a picture for me about how this data has revolutionized how we treat hormone receptor positive breast cancer?
Josh, I might start with the most important of our 3 studies, the most important because it actually has survival benefit data, spoiler alert, and that is with Mona Lisa 2. Other studies outside of the ribociclib space include Monarch 3 with Abemaciclib and Paloma 2 with Palbociclib. And I won't spoil the results of those. Suffice to say that they're not as impressive as Mona Lisa 2. So Mona Lisa 2 is a phase 3 randomized double-blinded trial investigating the benefit of ribociclib when combined with letrozole, specifically letrozole, versus a matching placebo in postmenopausal women with hormone receptor-positive, HER2-negative, recurrent or metastatic breast cancer. And Josh, to start off with a question purely based on that spiel, why in all of these studies would we exclude HER2-positive patients?
That's a great question, Michael, and I think the answer to that is relatively simple. If you inhibit just the CDK pathway, you're going to have another pathway that's going to be driving this, and in this case, it's the HER2 pathway, and ultimately we have such brilliant and effective treatments for the HER2 inhibition that you'd be juggling and potentially gambling with your medical license if you did not treat them with that first.
That's a very dire warning from Joshua Hurwitz, is don't juggle or gamble with your medical license. But it is true, and I guess in the HER2 positive space, in the triple positive space, you will prioritize the HER2 blockade, and we've talked about this in a previous episode with trastuzumab and pertuzumab, but you can always add on an aromatase inhibitor or other endocrine therapy on top of that to really get the triple block. But back to Mona Lisa. The study randomly assigned patients 1-to-1 to receive either ribociclib oral from day 1 to 21, followed by a 7-day break, which is a very standard regimen for CDK4/6, or a matching placebo in combination with letrozole. The eligibility criteria were quite broad. Patients had to be postmenopausal, they had to have a good functional status of an ECOG 0-1, and adequate bone marrow and organ function, so fairly standard stuff. Patients were excluded if they'd had previous treatment for metastatic breast cancer, although they did allow adjuvant or neoadjuvant chemotherapy. Patients were stratified by the presence or absence of liver or lung metastases, and a big part of this question about ribociclib is how effective it is in patients with lots and lots of disease affecting the liver, disease affecting the lung, which we'll talk about in a moment.
Would you reference that as a visceral crisis, Michael, with high burden of disease?
Well, I mean, if they had a visceral crisis when they entered screening for the study, they would have been excluded because they would not have had adequate organ function. But I guess higher burden of disease, a higher number of disease sites, metastatic disease sites, will put someone at an increased risk of a visceral crisis down the road. The primary endpoint was progression-free survival, which has been published several years ago. We'll still cover it though. The secondary endpoints were overall survival, chemotherapy-free survival, and an analysis of subsequent antineoplastic therapies. There were 668 patients in the study, and one thing that the authors noted is that there was a very small proportion of patients who were non-Caucasian, which they attributed to the recruitment drive taking place almost entirely in North America. So a little over 80% of patients were Caucasian, as compared with 8.4% people of Asian origin, and 3% of patients were African or African American. In terms of other key demographic data, 35% of patients had 2 metastatic sites, and 34% of patients had 3 or more metastatic sites. The most common sites of metastases were bones in 73.7% of patients, and 20% of patients had bone-only metastatic disease. And as we mentioned before, the viscera, which were defined as lung, liver, or other, quote-unquote, and 59% of patients had visceral disease. So they're not selecting patients with very low burdens of disease, where you would expect there to be a good outcome with the trial drug. But I guess, as we'll see with the results, and as you mentioned before, Josh, endocrine therapy by itself is still a bloody good treatment. So perhaps by trying to select for quote-unquote higher risk patients, they're trying to see definitively if the addition of a CDK4/6 inhibitor will provide a benefit where it's needed most.
I think that's it, Michael, with a lot of our treatments, especially breast, with such good overall survival already. Having the ability to discern actual benefit in a high-risk population is probably beneficial for the patient.
That is very true. And as we'll see, and as I'm sure you have experienced in your clinical practice, Josh, as well, the toxicity profile of the CDK4/6 is relatively well tolerated. It's relatively minor. You do have the occasional patients who have significant toxicity, but they're very much in the minority. So it's not a case of a small benefit at a potentially significant cost, but it is, of course, something to consider because you do have patients who, for one reason or another, are really not candidates for CDK4/6. Anyway, let's drill down into the results here. So the progression-free survival, we've known for a number of years that the addition of ribociclib does significantly increase progression-free survival, 25.3 months compared to 16 months with a hazard ratio of 0.57, and this was statistically significant. Interestingly, this benefit was maintained regardless of the presence or absence of multiple mutations, including PIK3 kinase, TP53 mutation status, P16 protein expression, and interestingly, Josh, this was the one I found most interesting, Ki67 expression. For those who don't know, most probably do, but Ki67 is a marker of cell turnover, and a higher Ki67 is associated with a more rapidly dividing and therefore more aggressive tumour type. But the benefit of a CDK4/6 addition to endocrine therapy was seen regardless of Ki67 expression.
That is interesting, Michael, and I think it does come to the fact that breast cancers are heterogeneous, but also there are multiple drivers of aggressiveness, and it's not just Ki67 that plays that role.
You're absolutely right. There's still so many drivers and markers that we probably don't know about and will discover in the future. But this is the important bit, Josh. The overall survival. And this was only recently published, but it has sent, I don't know if it did the same thing at your centre, but at my hospital, it sent shockwaves through the breast cancer clinic, and everyone was saying, oh, we really need to change things, because the overall survival was still significant. So in the intention to treat population, the overall survival with the combination was 63.9 months versus 51.4 months, with a hazard ratio of 0.76 and a p-value of 0.008. So definitely met statistical significance. And keep that 51.4 months in mind, because as Josh talks about his studies, we'll find that that is probably an accurate assessment of the overall survival with endocrine therapy alone in patients with metastatic hormone receptor positive breast cancer, because disclaimers about cross-trial comparisons aside, it is remarkably consistent across the three trials that we'll be talking about today. The 60-month overall survival rate was 52%, versus 43% in the endocrine therapy alone arm. So over half of our patients are now living more than 5 years, which 2 decades ago would have been inconceivable. The benefit was consistent across subgroups, but the magnitude did appear less in patients with visceral disease. So high volume visceral disease with greater than 3 sites. The overall survival was 55 months versus 46 months. In patients with liver disease, it was 37 months versus 38 months. And in lung disease, it was 59 months versus 52 months. Now, these are subgroup analyses, so you can't take them as gospel, and they shouldn't change your prescribing patterns, but it is something to think about and might be something to consider when we get final data on Abemaciclib as well. The time to subsequent chemotherapy, this was also very interesting, was 50.6 months versus 38.9 months. So if we compare that to the progression-free survival figures, people are still getting a benefit of treatment regardless of what arm they were in beyond progression. So it suggests that on average there was a period on treatment and then potentially a watch and wait time where the disease was relatively well controlled before they had to have subsequent chemotherapy. Looking at the total subsequent anti-neoplastic therapies, and this is something I wanted to ask you, Josh, a significant proportion of patients, 21.7%, had subsequent CDK4/6 therapy, the majority of them having Palbociclib. Have you seen CDK4/6 re-challenge in your practice?
Our practice, we generally do not re-challenge. In some preclinical data, this is unpublished stuff, they have seen that occasionally resistance wanes and you could potentially re-challenge. But most of the time, if I'm looking for a second-line option, we will look at a trial because that's the best way to get the best outcomes. The second one we'd be doing is probably chemotherapy because it's proven and effective.
The other option, of course, and remember these are patients who had letrozole, is in certain patients, is fulvestrant. So particularly in patients with a very strong endocrine driver, it is possible to switch from letrozole to fulvestrant and potentially keep the CDK4/6 going to try and break through that resistance. In terms of toxicity, there were higher rates of toxicity in the CDK4/6 group, with higher rates of neutropenia, diarrhea, and vomiting. Josh, there is one side effect that always gets drilled into us about ribociclib as compared to Palbo or Abema. Do you know what it is?
QTc prolongation.
Got it in one. This is our future breast specialist, everybody. But so QT prolongation is the main thing with Ribo. It's its own little quirk, and it's probably the one thing that separates it from Palbo and Abemaciclib, aside from obviously the overall survival data. But there was no new data on this in the update. So 2.7% of patients had prolonged QT versus absolutely 0% of patients in the endocrine therapy alone. So obviously when you're starting Ribo, it's important to do regular ECGs. At least for us, we do them for the first, I think, 2 or 3 cycles every couple of weeks. But once a patient is established on ribociclib, it's unlikely that they will subsequently develop QT prolongation. So bringing it all together, ribociclib has taken the gold medal in the great CDK4/6 race in that it is the first CDK4/6 inhibitor to definitively demonstrate overall survival benefit in patients with hormone receptor-positive breast cancer that is previously untreated. This does come at the price of a slightly increased toxicity, but again, remember that endocrine therapy is no slouch. So endocrine therapy by itself in this trial, people were still living for more than 4 years on average. And so if you have a patient, and we mentioned that there are patients who can't have CDK4/6, patients with significant heart problems or with pacemakers or a propensity for arrhythmia are the main ones. But endocrine therapy by itself is still a very good treatment. So that is the headliner of this episode, and Josh is going to deal with the lesser runners-up. But I guess this is, as we will see, based on evidence that has come out in the last couple of years, this has caused a significant change in prescribing where, Josh, I don't know about you, but when I started, Palbociclib was the CDK4/6 that tended to be prescribed most because it had what was thought to be a lesser side effect profile. It was not involved with the cardiac toxicity, but now physicians who previously prescribed a lot of Palbociclib on the basis of this evidence are switching to Ribo. And would you like to illustrate why?
I would love to illustrate why, Michael. Thanks for summarising Mona Lisa so very, very well. I have 4 different articles open up on my computer at the moment, and I will be talking about the Monarch 3 trial.
Just make sure you've got the right one up.
Oh, look, it's chronological, so I've gone from 2017. And you might be like, Josh, why 2017? there's been a lot of updates, a lot of differences that have come about, and I think it's important to briefly summarize. So the Monarch 3 trial was Abemaciclib as an initial therapy for advanced breast cancer. It was a double-blind, randomized phase 3 study which showed Abemaciclib or placebo plus a non-steroidal aromatase inhibitor in 493 post-menopausal women with hormone receptor positive, HER2 negative advanced breast cancer who have had no prior systemic therapy in the advanced setting. One of the differences with Abemaciclib, Michael, is it's actually a twice daily dosing. So usually it's 150 milligrams BD, and you either get letrozole or anastrozole, which is, once a day.
So patients are having to deal with a higher pill burden if they're doing Abemaciclib over, say, Palbo or Ribo.
Yes. And interesting, when we look at the breakdown of demographics, 30% of patients were of Asian background, which is, I guess, different to the Ribociclib group, which was predominantly a Caucasian. With these patients, at least 55% had metastatic recurrent disease, and another 40% in both arms had de novo metastatic. There were a couple that had loco-regionally recurrent, but I'm guessing they've defined those as metastatic as well, and they've got on the trial. The treatment-free interval, which I think is interesting, 60% had greater than 36 months. So this is a treatment interval before starting their first-line metastatic disease, and 28 to 40% had less than 36 months. Another thing to highlight is just the number of organ disease sites. About half in both arms had greater than 3 organ disease sites. Michael, in a breast cancer patient, what's the most common? We've done this before, but I might as well just hammer it in. What are the most common sites in breast cancer you'd expect something to spread to?
Well, bones would be predominantly number one.
Yep.
Liver is always a problem because significant liver toxicity, as you mentioned, can limit your therapeutic options.
Mm-hmm.
Lung, and we can't discount brain because breast cancer definitely does make a beeline for the brain, although it tends to be more the HER2 and triple negative ones than the hormone receptor positive ones.
That's it. But I love when you say beeline. It's great. So I wanted you to bring that up again, just like last time.
Beeline.
All right. Moving forward to the interim, I guess, results, and I will talk about updated analysis. So we saw a complete response in 1.5% of patients in the intervention arm. And interestingly, partial response in 46% and stable disease in another 46%. So clinical benefit was seen in about 78% of these patients, and in the placebo was about 71%. So at this time, it actually wasn't statistically significant, but the objective response rate was with a hazard p-value. The objective response rate was with a p-value of 0.02, with 48% having an objective response versus 34% in the placebo and non-steroidal AI. Other things to note in the forest plot is all age brackets benefited. Predominantly Asians benefited a lot more, but I do wonder if that's also a smaller cohort, but there were 148 patients in that particular cohort. We also found that patients with visceral metastases did benefit, but those with bone only were less likely to benefit, which is just something interesting to note. And there's been some updated data about giving anti-resorptive therapy in the metastatic hormone receptor space, and that actually does decrease bone-related events, but we will be talking about that more on one of our OncoSnack episodes.
Stay tuned for that.
Stay tuned for that. So what we've seen from this particular, I guess, first analysis is there was a progression-free survival that was statistically significant with a hazard ratio of 0.48. And obviously at this point, there was no overall survival, and they've kind of broken this down depending on a number of sort of key factors. I think when we talk about toxicities moving along, there is one big toxicity that can be pretty rough with Abemaciclib. Michael, which one is that?
That would be diarrhea, Josh.
That would be diarrhea. For those that start on Abemaciclib, they're actually given a pack, and this pack has some loperamide in it to help control it.
So added to the pill burden of taking a drug twice a day, you're also much more likely to need ancillary drugs, I guess is the most appropriate word for it, with things like loperamide.
That's exactly it. So 81% of patients had any grade of diarrhea, and grade 3 and grade 4 was about 10%. Ongoing from that, we can't forget neutropenia as well. With all of the CDK4/6 inhibitors, that's quite prolific. I mean, in a case such as this, you would generally delay by a week, and if you have recurrent neutropenia, then you would look at dose reduction. Moving on, Michael, I think I want to talk about the more updated trials, because that's the important thing. In 2019, Monarch 3 had a final PFS, which I will now talk to you about. What they found is an ongoing statistical benefit for progression-free survival. The Abemaciclib arm had a significantly longer median PFS than placebo. It was 28.18 months versus 14.76 months with a hazard ratio of 0.54. The objective response rate was 61% versus 45.5% in the placebo arm. And the median duration of response was longer in Abemaciclib, which was 27.39 months, versus placebo, which is 17.46 months. If we go back to the start of our talk, we were talking about while endocrine therapy is very effective, resistance inevitably develops, and this shows that by inhibiting other pathways, you can control the cancer for a longer period of time. Again, in this particular study from 2019, we did not have an overall survival benefit at that point. If we're looking at things like waterfall plots, you do again see a benefit in Abemaciclib and a non-steroidal AI. You can also see the median percentage change in tumor size is better in Abemaciclib and AI, so generally about 70 to 80% versus about 40 to 50% in placebo plus AI as well. So you're actually seeing quite significant differences when it comes to tumor control, tumor regression as well.
But it's not statistically significant, is it, Josh? It's only a trend towards overall survival.
Yes, well, so I will talk about that now, Mikey. Thanks for bringing that up. This is a update from 2022, so I've gone 2017, 2019, and now 2022. So the median overall survival for Abema plus a non-steroidal was 67.1 months versus 54.5 months at that point, with a p-value of 0.03, but it did not breach their threshold, which is the issue. They needed more events in either the placebo or the Abemaciclib arm. And interesting, as per our prior conversation with your trials, Michael, looking at those that received subsequent CDK4/6 inhibitor therapy, 31% in the Abemaciclib arm went on to receive a subsequent 31.5% went to receive a subsequent CDK4/6 inhibitor, and 10% in the placebo, which I found really interesting.
That is interesting.
Maybe there was crossover that I have not alluded to for our lovely listeners here, but that seems very strange. I would have smacked someone on a CDK4/6 inhibitor the second I knew they were progressing.
You'd almost expect it to be the other way around, with more people getting subsequent CDK on the control arm.
Exactly. I'm not exactly sure why. It would be something interesting to maybe talk about at a later date. Again, toxicities were as we expected. So why there is a numerically favorable overall survival difference in the intention to treat population and visceral disease population observed with Abemaciclib and a non-steroidal AI versus the placebo arm, there was no statistical significance because it did not meet the pre-planned threshold. There was a greater than 12-month overall survival difference between control and intervention arm, and there was overall survival benefit found across multiple subgroups that is, worthwhile kind of highlighting. But again, none of these were particularly statistically significant, so I can't, recommend this. The thing is, we need ongoing follow-up for this mature OS. It's looking like there will be statistical significance based on the difference between the control and the intervention, but right now we can't say anything.
So it's not yet a viable alternative to ribociclib from a statistical perspective, Josh?
I do not believe so. I think looking at these numbers, it's really difficult to say, well, you have statistical benefit in the ribociclib arm, you do not have statistical benefit in the you do not have statistical benefit in the abemaciclib arm.
One thing that I did like about Monarch 3 is their specific focus on patients with visceral disease. So they actually, rather than sort of having a post hoc subgroup analysis, they've actually got a prospective subgroup where they look at outcomes in patients with visceral disease, and the benefit there is quite significant, which would be something that would be interesting to look at, because that very well may be where Abema finds its niche in the future, if it does prove to have a statistically significant overall survival benefit, is it becomes the mode of choice in patients with high volume disease.
And that's exactly right. And anecdotally, I had a patient who was in a situation with quite high burden of visceral disease, and we put them on abemaciclib, and there were some pretty ridiculously amazing outcomes for this patient. And so, again, anecdotal evidence is pretty low, but if you look at, just to kind of flag what Michael said, if you look at the number of organs involved at baseline, and then you look at the hazard ratio, it's 0.79 for that, and while the p-value is 0.441, you then have to ask yourself the question, it's like, okay, maybe there is some benefit there that we need to kind of focus on.
It's very much a watch and wait approach regarding abemaciclib, and it very well may carve out its own particular point, or its own particular niche in the metastatic hormone receptor positive space. One drug that may not have a niche anymore is the third of our intrepid trio of CDK4/6 inhibitors, and that's palbociclib, because this is the one, and we've sort of taken this in a stepwise approach. We've gone from definite yes to a maybe, and now we're unfortunately at the part of the program where we're at the definite no stage. Would you like to talk about Paloma?
I would love to, or Paloma 2, Michael, but yes, I'd love to talk about Paloma.
Or just Paloma in general.
Paloma. So Paloma 2 was a multi-center international double-blinded randomized phase 3 trial, was looking at palbociclib plus letrozole versus placebo plus letrozole. The primary endpoint was a PFS, so progression-free survival, and the secondary endpoint was overall survival. Similar cohorts, hormone receptor positive, HER2 negative, advanced breast cancer, no prior treatment scheduling, and that's something that's important. We found visceral disease in about 50% of each of the patients, and if we look at disease-free interval, 40% had greater than 12 months and 22% had less than 12 months, and another 40% were about de novo metastatic disease. When we look at the intention to treat overall survival, Michael, palbociclib was 53.9 months versus placebo was 51.2 months, with a hazard ratio of 0.95 across that statistical interval of 1 and had a p-value of 0.3378. The post-hoc sensitivity analysis, not exactly sure what that is, but essentially it still wasn't statistically significant. And median duration of treatment was 22 months versus 13.8 months. And discontinued study treatment was, I guess, 90% of patients, because evidently they've progressed at the time of this analysis. With the final OS analysis, the post-study systemic therapies were quite interesting. Probably 50 to 60% of both arms were actually switched to chemotherapy, predominantly capecitabine, a taxane, or an anthracycline. Only about 12% went on to another CDK4/6 inhibitor, and about 30% of the placebo arm into another CDK4/6 inhibitor. Toxicities, neutropenia was far worse in this particular arm, 82%, and if you go down to diarrhea, only 30%, which is probably why from a clinician perspective, we would use palbociclib more than, let's say, abemaciclib from a quality of life perspective. So unfortunately, there is no overall survival benefit of giving palbociclib versus, let's say, ribociclib or maybe even abemaciclib.
It is probably the black sheep of the CDK4/6 family in that it is almost certainly the one that's going to fall by the wayside. I guess, Josh, a couple of things about this. How has this news of a lack of statistical significance in the overall survival setting, how has this news affected prescribing behaviour on your end? I've mentioned that it's caused quite a significant change in the places I've worked, but has it had a significant impact on your practice and the practice of the specialists you work with? Because there is a proportion of people who basically sort of clump these three agents together, and despite the numbers, still say that if ribociclib is better, then it's probable that all of them have a benefit over endocrine therapy alone.
And in saying that, Michael, they probably all do have a benefit over endocrine therapy alone, but you have to take into account all the other facets of this drug rather than just a numerical value. I think the practice I have seen with the specialists I work with is, yes, it has made a difference. It's very difficult to convince someone to go on palbociclib if the overall survival data is not there. Ribociclib is your choice, really, because I think abemaciclib for the first couple of months can be quite rough to tolerate. And I say this because I find with patients who are on these inhibitors, while they have potentially pretty difficult toxicities early on, it actually improves over time.
And I guess the other hypothetical I wanted to run by you, Josh, say, for example, and this is a very narrow hypothetical, but say, for example, you had a patient who had significant cardiac toxicity. Remember that a large proportion of women who have metastatic hormone receptor positive breast cancer patient are postmenopausal, older, more comorbid. You have a patient with cardiac toxicity who does not like the sound of the diarrhea related to abemaciclib, and so your choices are endocrine therapy alone or palbociclib, and you have no other CDK4/6 options. Would you still give them palbo, or would you go endocrine therapy alone?
That's such a difficult question to answer, Michael. I think you could give them endocrine therapy alone. I think that's going to be a conversation with the patient, because on one side there's a numerical benefit, not a statistical benefit. And let's say they have no toxicities, there's probably no harm by giving that CDK4/6 inhibitor. I think if it was my practice, I'd be very much trying to convince them to have the CDK4/6. I think that would be their best interest. So ribociclib in this case, or abemaciclib given their cardiac toxicities for this specific patient. But you could try an endocrine therapy. You could even try fulvestrant, which has shown some benefit as a single agent and is no slouch.
That's a very valid response, Josh. I didn't really have an opinion one way or the other, but I was interested to see what you would think. Like you say, it's probably best that you discuss it with the patient, because palbociclib, that's sort of our get out of jail free card here. But palbociclib does have its own side effects, so it's important that you lay it out.
Pretty much. So as a summary in 3 sentences or less, ribociclib remains the gold standard for now, with abemaciclib hot on its heels, whereas poor palbociclib, due to a number of factors, has come in 3rd place.
Absolutely. So that wraps it up for today. Thank you very much for listening to Oncology for the Inquisitive Mind, and join us next time where we'll be starting a very rambly, complex journey full of missteps and shortcuts into the world of early head and neck cancer. This is something that you don't often see unless you're in a centre that's built for it, but it is definitely one to know. So we look forward to seeing you next week.